afternoon, viewers. We're back again today with another session in our series on best practices in substance use treatment. We're beginning this journey with 5 digital workshops, but we'll continue to add to these in the upcoming months. We know that you're aware that there's a lot to running a successful treatment program, and we can't stress enough how important it is to have a consistent philosophy for treatment so you can send a consistent message to your clients. This is really the catalyst for our taping of these workshops. We recommend watching these sessions with your staff or minimally holding discussions on these topics. Mindsets like how you and your team of professionals view addiction or what type of therapies to use in your facility have to be similar so that patients get a unified treatment program, regardless of which therapist, family coordinator, or other staff member a patient comes in contact with. My name is Catherine Hendrick, and I'm a case manager at Addiction Treatment Strategies, ATS, located in Edwardsville, Illinois, just outside of St. Louis. Addiction Treatment Strategies is a 6-month intensive outpatient treatment program. We are a therapeutically based, medically assisted substance use disorder program, which provides an extremely effective treatment program. Today's session is going to be led by the founder of Addiction Treatment Strategies, John Crum. And John, at this time, I'm going to go ahead and ask you, if you can, to talk a little bit about how the Southern Illinois Health Foundation and Addiction Treatment Strategies, ATS, started collaborating.
Well, we were very fortunate to be a part of the Surgeon General and the Secretary of Health and Human Services and the Secretary of SAMHSA, Substance Abuse Mental Health Services Administration, wanted to see what a medically assisted treatment program was all about. So they were kind of going on a brief tour of the United States facilities, and we happened to be one of those selected. And at that point, we had a lot of judges and elected officials here, in addition to the executive director of SIF was also in attendance. And we went through our module here of how we provided treatment, and then we established a collaborative relationship with SIF to work together and see if we couldn't improve services to patients.
Yeah, that was a big day. If I remember, that was a really big day when we were able to tell kind of our story to everyone. So today we're going to talk a little bit about a quick entry point into treatment, and it's called Sbirt. So I'm going to go ahead and pull up this presentation for everybody and talk about what exactly Sbirt is. So Sbirt is an approach for the prevention and treatment of substance use disorders. It's a comprehensive public health model approach to delivering care for individuals who have or are at risk of developing a substance use disorder. It's a harm reduction model effective in reducing substance use in individuals whose use places them at higher risk for negative health and social consequences. So the approach of Sbirt is not that you really need to stop drinking altogether. It's not that that's what their ultimate goal is, but that you might consider limiting drinking within some sort of safe limit or the not so risky limits. And the intent of most public health models is really to reduce the impact of a particular problem on a community or a society. So John, when you look at Sbirt, what makes Sbirt, that model, different from others?
Well, I think you have to differentiate the intent. I mean, we've had all kinds of models that started with that treat with addiction. We have the moral model in the 1840s, a temperance model, American disease model, educational models, characterological models. In this particular case, we're talking about how public health gets involved in doing exactly what it sounds like. It's public health. So they're interested in the overall concept of how does this disease impacting on a community. So the first step in the Sbirt model is to screen someone quickly as they can to find out if the person is even having an alcohol substance use problem and how risky are they at some level of being dependent. Sbirt process uses some very brief, validated universal pre-screening and screening tools. They're very quick, sometimes as little as 6 or 8 questions, maybe up to 20 if you need to. And I think Sbirt is extremely respectful, like most public health processes, of the individual person making a decision in the process as to how much they wanted to be involved and how much change they needed, if any. So it's a screening tool more than anything else.
Okay, thank you. So why is it necessary? Although the national cost of substance use is approximately 740 billion annually, healthcare providers rarely use a validated tools to screen patients for a substance use disorder. The intervention is underutilized in healthcare settings, representing a substantial gap in implementation. And clinicians report that they infrequently use screening tools to screen for substance use, and clinical studies are not typically trained or have Sbirt experience. So, what are the benefits, John, do you think of Sbirt?
I think it's a brief screening tool that gets people involved in the system very quickly. It's
Mhm.
non-threatening. It's easy to administer. I think it refers people to treatment and determines whether they need treatment or whether they need to be referred somewhere else. So it's a very quick tool.
Okay. It's nice for us to be able to tell everybody that we think that this is a nice tool. But we're going to go ahead, and if I can pull this up, we're going to watch some video testimonials. So give me just 1 second, and I'm going to try to do this here. Here we go. All right.
I started using when I was 36 years old. I started with pot, and I was making a lot of money at that point, so I started using cocaine after that, and then I went to methamphetamine.
When you organize your day for purposes of drinking and the highlight is being able to finish your work, hustle off to a bar, hope to be there by noontime, take advantage of happy hours, buy in advance, there are bound to be consequences.
I was having a lot of dental work done, and I was prescribed Vicodin, and my dentist seemed to just give it to me all the time, anytime I needed it, and I became dependent on it. I had a habit and could no longer find Vicodin, and I started smoking heroin.
I was a teacher. Towards the end of my drinking, I actually drank before classes, in between classes, after classes, on the way home, and then to oblivion.
I didn't really recognize it as being a problem, despite the two DUIs, despite um, the interactions with my wife, where I would promise to quit drinking and then not and get caught.
I chose a individual to be in my life who physically abused me, and so I went to the doctor. I went to the doctor several times. I don't recall ever being asked anything about my addiction.
The physicians I saw didn't ask anything about substance abuse. They didn't ask me how much did you drink. They asked me things like, are you depressed? Are you nervous?
Well, in fact, it was never a subject that came up because the doctor had no idea that I was drinking and never assumed that I was. So, yes, I think it would have been helpful to have been approached.
One of the things that helped me was having a screening form where I could write it down, where I didn't have to say it eye to eye. And then the doctor could read it and then bring it up to me.
Is it appropriate for the doctor to, you know, based on my answers to a questionnaire, recommend or, give his analysis or his opinion of where I fall? Yeah, I do think it's appropriate.
I would fill it out, and I think I would fill it out honestly. A form like that has a certain anonymity to it.
Whether the patient takes that with him or her and thinks about it, that's a step in the right direction. Or if there is a dialogue that ensues between patient and physician.
I think that it would be worth the time to refer them to someone or provide them with a resource list. Whether they're willing to take the list at that time or not, there might be another time when they are more willing.
DUIs required treatment, but I didn't benefit from the required treatment at all. The only time I've truly benefited is when I chose the treatment or chose to accept the treatment. And the benefits of that have been very high.
You know, maybe the doctors could help by only prescribing narcotics for a certain length of time. I've gotten kidney stones, which are very, very painful. And I've never been given more than 10 pills at a time. And there's really not an opportunity for me to abuse that or to become addicted with 10 pills.
I was on stimulant medication for ADD. I was taking Adderall. And I found myself with two sources for my ADD meds. I took advantage of that. I doubled up on my ADD meds. And then I got caught by the pharmacy. I almost lost something that was really, really precious to me, which was my relationship with my doctor here.
When I relapsed, I felt I had actually failed my doctor. And I told her I felt I had failed her. And the response that I got was that I had not failed her, that I had relapsed, and that relapse is common, and that now you need to assess where you are. You need to assess why you relapsed. And we need to put together a plan to avoid a relapse in the future if you want to move forward.
Being able to have a doctor that I can be honest with and truthful to at all times has been a blessing. It's made it much easier to stay clean and sober.
Today, of course, I'm in the care of a physician who knows a great deal about substance abuse. And every time she sees me, she congratulates me on my continued sobriety. And it's her enthusiasm that, makes me look forward to any office visit that I have with her.
It can make a big difference. It's made a huge difference for me in the last 7 years.
Most addicted persons want to be healthier and happier.
My main take-home message to doctors would be, don't be afraid to ask. It might help save a person's life.
All right. Okay, John. Let me go ahead and pull this presentation back up here.
Okay.
There we go. Okay. What are your thoughts about that, John, about some of those comments that some of those people were saying in regards to, just asking, open my eyes, completing a form, open my eyes?
I think that was that was at a time, and we're probably still at some of that time right now, where doctors don't ask the question about substance abuse, probably about fentanyl use, perhaps, but certainly I think they shy away from alcohol use. And I know that some physicians, if you tell them you're using, they may ask you how much, and the usual response, if they're not aware of how complex an addiction issue is, will say, "Well, just try to cut back," and that kind of ends the conversation. So I don't think they pry or probe into the nature of what addiction means. I think they certainly treat the byproducts of that in terms of maybe kidney problems, liver problems, elevated liver enzymes. They'll treat that, but I don't know that they necessarily tie that to some type of brief intervention or some type of questionnaire that somebody could, like the lady said, fill out anonymously so that she's not confronted directly by the physician, and they could fill it out and tell them what's going on, which would be obviously a component of a screening.
Mm-hmm. And with the doctor, a trusted individual that doesn't have any history, familial history. There's not an emotion. It's very, very much here is my issue. How can you help? I'm not having to share with family members the same way as well. Makes that step sometimes just a little bit easier. So, John, talk a little bit about the history behind Sbirt. How did it come into play, and what precipitated that need for this model?
Well, I think things like everything else, they go in a cycle. I know that Sbirt was popular in the 60s, and it kind of resurfaced again in the 80s. I think it points out a couple of things. One, the problem was becoming more apparent. Not necessarily that we weren't aware of it, but no one had really taken an active role in addressing the issue. So when the public health model came up, it was that significant that public health was aware that
Mhm.
addiction was causing some legitimate problems, and not just for the individual, that it had become a public health issue. It had become a national movement. So I think we had moved at that point from moving to a specific individual who had the problem to community was the community of physicians or public health was willing to take on the role of championing the cause to get people better. I think I believe more physicians were becoming more involved with awareness of alcohol at that time, and it was reaching they already knew it reaching impact on certain bodily functions, and it wasn't simply an innocuous substance anymore, and people were having more and more impact on the rest of their life, not just drinking, but obviously family dynamics and divorce, all those things were playing a role, and physicians became more involved in the 80s in that.
Okay. So why did the World Health Organization get involved when it did, John? Was something going on nationally, politically?
Lots of things were going on in the 80s. I think with regards to the World Health Organization, they begin to look at things primarily because of 148 countries all over the world, 120 of them had reported HIV infections. So I think that was a precipitating event that said, hey, we need to look at what's causing HIV infections. And it was intravenous drug use. So people became very, very concerned. And it got their attention because people were dying as a result of AIDS. And most of that, a lot of that was as a result of sharing needles. So they became very, very interested. They also knew that about 3.3 million deaths annually were related to alcohol use alone. I think that's the beginning of the awareness by the World Health Organization. It was HIV, and the millions of people were dying just with what appeared to be simple alcohol. There are a number of factors, obviously locally, if we call the United States locally. That was the Nancy Reagan Just Say No on drugs. That was the war on drugs policies, the Just Say No, and probably the opiate epidemic was becoming at least more aware, or at least the beginning stages of that, when there was an article published in the New England Journal of Medicine, which is the hallmark medical publication that published on OxyContin, that said that of 11,000 people tested, only two people developed an addiction to OxyContin. Even though Purdue Pharma was ultimately, if you will, marketing or marketing this drug as non-addicting, and the physicians believed not only what Pharma said, or believed what Purdue Pharma said, but they also believed what the article in the New England Journal of Medicine had said. So as a result of that, a couple of things happened. We increased the number of people who were becoming addicted as a result of oxycodone, and physicians were operating under the belief that it wasn't addicting anyhow. So we had the World Health Organization, we had national politics with Just Say No, we had the war on drugs, and we had the physicians who were just beginning to understand, or at least be involved in the process of giving more and more OxyContin, which developed a great number of the addiction problems that we have today.
Okay, and then John, I know that these current teaching approaches in med school, is it a good thing that our doctors have quick screening tools like we're going to share here, because they're receiving very little emphasis on addiction in their programs?
I think it would be fantastic if they would just include, maybe even our course on Sbirt. I mean, I think doctors need to be asking for that. As you mentioned, they're the trusted professional people. Even though we know that our patients may be somewhat deceitful, if the doctor's asking questions, they administered like a simple cage questionnaire that we'll get to in a minute. Just ask 3 or 4 questions. That at least points you in a direction. So I think physicians probably shy away from asking questions on alcohol, because it's generally accepted in our society. So everybody drinks. It's just some people have addiction issues, some people don't. But I think they shy away from a screening tool.
Okay. And so I thought it would be helpful if we kind of listed just some simple screening tools that seem to be popular right now and are easy to implement. The first that comes to mind is something called a CAGE questionnaire. And that's an acronym, and it stands for, or what they're trying to explain is, the first is cut down on drinking, annoyances with criticisms about drinking, guilt about using, or using substances as an eye opener. And the questions that it asks, it's very simple. It's 4 straightforward yes, no questions that clinicians can easily remember. So it's not like they even have to have a clipboard in front of them and be asking these questions in a formal manner. It helps them to be a little bit more informal. Have you ever felt you should cut down on your drinking? There's the C. Have people annoyed you by criticizing your drinking? Have you ever felt bad or guilty about your drinking? And have you ever had a drink first thing in the morning to steady your nerves to get rid of a hangover? Is that the eye opener there? So it's self-administered, or it can be conducted by a clinician. Like I said, just those couple questions there. It's a proven utility for use in routine health screenings of adults and adolescents, and it takes about a minute to administer. So John, give us just a little bit more information on the CAGE as a screening tool.
Well, I think the CAGE is probably my favorite tool because you don't necessarily, the patient doesn't have to necessarily know that you're administering a tool. So in the form of a conversation, you can be talking about something and say, have you ever thought, told me you drank a little bit. Have you ever tried to cut back on drinking? Okay. And then you can say, well, what were the effects of that? Did you try this? Did you try that? All that other stuff. So you can carry on that conversation, and then you can ask the other question that comes right after that. So have you ever been annoyed by the fact that people criticize you about your drinking? And then you can build that into regular just a conversation with the patient. And I think the part that people don't understand in terms of, there's an extreme great deal of reliance for answer yes to all 4, then using it as an Sbirt screening tool, then you probably have about a 98% chance of having a drinking disorder. And that's a reliable number. 98% chance if you answer 4 correct, or you answer 4 yes, about an 88% chance if you answer 3. So that would indicate that you probably have a problem and need to be referred for treatment. And if you answer 2 of them correctly, or 2 of them saying yes, that's about a 72% chance. So, I mean, those are all statistically significant numbers that a very simple thing, if we've answered 4 out of 4, that's a 98% chance that you have a drinking problem. And you probably either need to be treated by that physician or a physician who specifically works with drinking and alcohol substance problem. And it's very, very easy to administer.
Yeah, and I think that's nice. And it seems like it's extremely easy to score.
Yeah.
Well, when you just kind of.
Even I can do it.
Yeah. Maybe even I can do it as well. So the next tool we were going to talk about was the drug abuse screening test, or the DAST. So John, are you familiar with this one? Can you give us some information on it?
Yes, there's a DAST 10 and a DAST 20, and there's 10 questions versus 20 questions. They're all very, very simple. It's a yes, no. It patterns itself after one of the oldest ones around, which is the Michigan Alcohol Substance Screening Test. They're all about the same. You answer yes or no to something, and then there's a cutoff margin that tells you this is what, and there's the answers are all on the back. So if somebody wants to pull these up off the internet, they're all free. You can download them, and the DAST is just another one of those tools. It may take, I don't know, 4 or 5 minutes to administer. If you give it to a person, you can give it to the person in your waiting room and they can fill that out. And then that prompts some discussion questions that the physician or whoever the clinician is determines whether they need to be referred for more treatment.
Okay. Now this one I know you're familiar with. This next one is the clinical opiate withdrawal scale. Talk about this one, John.
Yeah, we've used that one here for quite some time, and that's for people who are already using drugs and substances, and we know that. So we use the COW scale to determine when the medication that our physician uses, obviously, as most outpatient treatment, use Suboxone. So the COW scale tells us when the person can safely start to be administered Suboxone to help them through the withdrawal process. And when they reach the moderate to severe stage, and those are the 11 items on there, which goes from rhinitis to runny nose to sweating and all those things they're easy blood pressure, easy to see when they get into the scale where you can actually administer Suboxone to help them through the withdrawal process. The COW scale tells us very objectively when that can be done, but it's still no substitute for ask the patient when was the last time that they used. When do they typically go into withdrawal? Have they ever been on Suboxone before? Have they ever had the COW score administered to them? The patient is probably, with regards to opiates, is the best reporter of what's going on, because the last thing that we want to do with an opiate is to induce withdrawal. And if we give them a Suboxone before they're ready, then we do what's called precipitated withdrawal, and that'll make them extremely sick. So you want to make sure that there's sufficient opiate or insufficient opiate on the system so that we can administer the medication that usually takes about 14 minutes to make them feel comfortable. So then we can take it from there.
Yeah. And then they can access treatment much
Right.
better. Okay, the last one that we have here is called the Craft. And of course, when we're saying the last one, these are just a few of the most popular screening tools out there currently. So what do you know about this one, John?
Well, the craft is for adolescents. The CRAFFT, stands for car, relax, alone, forget, friends, trouble. You can ask it 6 questions. It's very easy to do. It's validated for just about everyone. Obviously, the American Academy of Pediatrics recommends it as a component of scare and screening. It's designed to identify the beginning use of substances and any type of substance-related driving risk in any adolescents who's drinking or smoking is at risk for driving because it impairs everything. So the craft is a very, very easy one. It's well studied and well documented.
Okay. So John, a little bit of a conclusion here on some of these interview tools.
Well, to start an interview, if you really don't have much experience with it, it's just you're starting to talk to people. There's no specific one thing that you need to do or not do, and it's a social contact. From they may be scared or frightened about what's going on in the process. Say, hey, why are you here today? How can I help you? So you start the conversation by engaging them and getting them to talk about what's going on. And then once they begin to warm up a little bit, you can ask the question 3, have you been using any substances in the last 30 days? And then you say, do you drink regularly? How much? If how often? Then you can go right to the cage, or you can put the cage questionnaires in there. And then what we're looking at as part of Sbirt is, even though we have screening tools, there's no substitute for a clinician's judgment. So once you use one of these tools, you get comfortable using the tools. If there's any doubt, refer. Make sure somebody else does a more extensive exam on them. I mean, you can do any one of that. You can do an audit. You can do other tests. You can spend more time with them to see, because the primary thing is to get people referred to treatment, and take your time. I think that's the main thing. Don't rush through anything. Physicians have very little time, but perhaps us as clinicians can spend a little more time in developing some type of relationship where we can determine whether they need to be referred for treatment or not.
Okay. Well, thank you, John, for talking today about Sbirt and giving us a little bit more information, and especially sharing some of those tools that are available. I was really surprised, as I was pulling up some of these tools to look to see that they're almost all just available online.
Yes.
All
And it
right.
doesn't take, somebody with an advanced degree in anything to do it. It takes somebody who's familiar with the concept, read the question, do 1 or 2, and you'll become an expert.
All right. Well, thank you, John, very much. Okay, viewers, if you're interested in obtaining CEU credit for today's workshop, what we need you to do is the following. Write a 2-page reflection paper on how your thinking has changed after watching this digital presentation, what attitudes have changed, what practices will change, and then just make sure that you're citing evidence from this presentation throughout that reflection paper. You will need to send that directly via email Carissa Vandenberg Clark. She is the assistant professor for family and community medicine at St. Louis University. And you can see I've left you her email address there. In the subject line, just make sure that you're putting that this is a CEU request for Sbirt, and not for stigma and its devastating consequences, but for Sbirt. Thank you very much. You know what, John? I will switch